Dear colleagues, please take your seats. My name is Kristian Reich. I really welcome you for what I would consider the second symposium on 23 inhibition, but it's really worth listening to the main theories, concepts, facts around inhibition of this important target again. And I'm absolutely happy that I can do this together with two very esteemed colleagues, Professor Bruce Strober from the US and Professor Curdin Conrad from Switzerland. What do you expect from this program? I think you can expect, again, to take a look at the role of 23 in the pathophysiology of psoriasis. This will be my part. You see the program here. And then Bruce will take us to the facts. What does blocking, inhibiting 23 really bring to our patients? So he will carefully review together with you the clinical data. And then I think we have a very important third talk, and this is helping you already understanding what does it really mean for my patient. We talked about this yesterday. We have more and more complexity, and I know this worries you. We have TNF inhibitors, several of them. We have ustekinumab, good drug. We have 17 inhibitors, A receptor blockers, good drugs. We now have 23 inhibitors. We are talking about the first 23 inhibitor today, but there's a second, there's a third one. So the complexity is increasing, and what Curdin will do is he will try to give you some basic guidance that you can use to manage this in your daily practice and to select the right therapy for your patient. So let's get started. I like to talk about the models of psoriasis. These are my potential conflicts of interest. I like to talk about the models of psoriasis. And actually, we speakers that talk about these models, we all cheat. Right? We say, look how clever we are, and we have done this research, and we have developed our models, and then we have identified the targets, and then we use them, and we see fantastic response. Truth is that I myself was running around, and I know that Bruce was doing this for many years, saying psoriasis is a Th1 disease. Right? We had patients that used interferon for the treatment of hepatitis, and they immunologically Koebnerized their psoriasis. I did a study 20 years ago where we injected the anti-Th1 cytokine interleukin-10 into patients, and we saw a good response. Jim Kruger did a study where he injected interferon into the skin of healthy patients, and they developed a psoriasis-like dermatitis. So for many years, I was actually convinced that psoriasis is a Th1 disease and atopic dermatitis is a Th2 disease. Remember these days? The yin and yang of immunodermatology, right? And we thought that TNFs would work because TNF is a signature cytokine of this Th1 response. Then we have ustekinumab, 17 inhibitors, and now we block 23, and surprise, surprise, these drugs work better than anything else. So the truth is, as we got the reality on our table, as we got the clinical facts, we modified our models. So when I present now models to you, please be always aware that 20% is hope, 30% is vision, and 50% is probably wrong, right? So models are models. They should help you to understand what you see in your clinic, and if we see something in our clinic that doesn't match our model, we will change our model, right? Okay, good. One concept that I think is extremely important is the concept of disease domains, and Bruce will come back to this when he talks about the clinical trials. None of our patients is the same as the next patient. We have patients with scalp, with palmoplantar, pustular, non-pustular, nail disease, genital disease. Even we dermatologists begin to understand that there are domains in psoriatic arthritis. Spine involvement, enthesitis, dactylitis, peripheral arthritis. Why do I say this? Because there is increasing evidence that the cytokine pathways that we discuss may differentially contribute to the different disease domains. What does this mean for you? It may mean that if you have a patient with plaques and nails and arthritis, you have to select a different targeted therapies compared to a patient that has only plaques and cardiovascular comorbidity. Right? So I think this is an important concept to have it in the back of your mind. So I jump over the question, what do you think patients want? Don't look at the slide. Yeah, you know this. What do you think patients want? Safe control, clearance? That's actually an interesting study, and there are other studies that point into the same direction. That is the hierarchy of the wishes, right? So you see the numbers down here. So they want a reduction in itch, but the wish that comes out on top of the hierarchy is to have skin healing, so clear skin. And actually, I think we should try to achieve this today. And one beauty of the 23 inhibitors is that we can, more than ever, actually try to achieve this goal. You have here a psoriatic plaque. You take a biopsy from this plaque, normal skin, yeah, active psoriasis. It's textbook knowledge. Don't take a photo. It's textbook knowledge, right? You see here stratum papillare, stratum reticulare. You see what happens in psoriasis. You have a thickening of the stratum corneum, hyperkeratosis. The cells that are normally apoptotic and have no nucleus all have a nucleus, parakeratosis. The thickening of the epidermis, the acanthosis, and then you have millions of cells that infiltrate, and as you know, these are mostly T cells and neutrophils. And we do think that T cells are major drivers, but they do not work on their own. We do think that there is a cell that acts like an immunologic teacher, and this cell is the dendritic cell. Now, if you stain for a marker for dendritic cells, this is what you get. You see here, these are all dendritic cells, and these are the T cells. So they co-localize. They sit in direct vicinity. They talk to each other. And this crosstalk between dendritic cells and T cells, the immunologic synapse, and the understanding of this crosstalk is nowadays what I would consider a main target, not only for inflammation, but also for oncology. Yeah, those of you in the room that have an interest in malignant melanoma, you know that the new hot drugs for malignant melanoma, they all manipulate this crosstalk between dendritic cells and T cells. For example, by using ipilimumab, you block an inhibitory costimulatory molecule, and you do the same with the so-called checkpoint inhibitors. So the immunologic teachers, and in addition to the molecules that give you the direct contact, these teachers release what I would call an educational cytokine. So the responding T cell now knows what to do. And this is the key educational cytokine for Th1 development, and this is the key educational cytokine for Th17 development. And the name comes from the fact that these cells have IL-17 as a signature cytokine, right? Now, this was a model published 10 years ago in the New England Journal. First of all, you see no neutrophil on this. That's interesting because psoriasis is the disease with neutrophils. And I can also tell you that nowadays, we know that this pathway is not exaggerated in psoriasis. It's not overexpressed. It's actually this pathway that is overexpressed in the disease. This is a Jim Kruger slide. I like him, I like his slides, but from my normal brain, they are very complex. You at least have 32 arrows on the slide. Right? But the message that is central in this slide is, number one, the immune system is doing something with keratinocytes. This crosstalk between dendritic cells and T cells leads to the release of cytokines such as IL-17 that activate the keratinocyte, that initiate this epidermal pathology that I showed you on the slide. But there is a second message included here. And take this home, because this will be something for the future, that once activated, keratinocytes themselves are a very active source of cytokines, mediators, that then will signal back and modulate the immune system. And among these epidermally derived cytokines is IL-1 alpha, is IL-19, is IL-39, is IL-17C. And if you follow this congress, you know that all these epidermally derived cytokines will be relevant targets in the future. So you have a feed-forward response and you have a feed-backward response. That's, I think, important to remember. Is there anything new about good old TNF? I think there is. This is a study that for the first time used an immunohistological technique that would allow you to really stain TNF-producing cells in the skin. And interestingly, only two main cell types were found to make TNF. These are both antigen-presenting cells, certain macrophages and dermal dendritic cells. So in Kristian Reich's simplified version, this is the first model that you can probably take home. In psoriasis, you have an activation of dendritic cells that sit in the epidermis. They will make TNF, that together with 17 activates keratinocytes, and they will make 23, what activates neutrophils and T cells to make 17. Right? So that's a simple model. You understand now why TNF plays a role, because it acts synergistically with 17 to activate keratinocytes, and you understand why 23 plays a role, because it's the upstream event that makes certain cells produce 17. Now, unfortunately, and it comes back to what I said earlier about models, this model does not explain certain things that I see. There is a little candida signal when I block 17. Blocking 17 may lead in some patients to the exacerbation of IBD. But there is no candida signal with any of the 23 inhibitors. And many of them are developed as new therapies for IBD as we speak. So a simple upstream-downstream model could not explain this. And this slide you are seeing now for the third time. We all use this. And again, it's another model. It's a model. But this model explained to you that as we sit here, we all have 17 in our skin, and there is a healthy background physiological production of 17 that helps our skin, for example, to not get candida infections. But in the presence of 23, this so-called pathogenic Th17 population develops. Of course, we don't give 17 blockers to patients that have normal 17 levels. We give 17 blockers to patients that have elevated 17 levels, and we want to normalize them. But obviously, in some patients, we oversuppress, and these patients may be at an increased risk to get candida infections. And we don't see this with the blocking of 23. No? Be aware that the molecules that we use are also different. This is a very old slide, but just as a reminder, we have fusion proteins, we have antibodies, and with certolizumab, we discussed this in an earlier symposium, we now even have a pegylated Fab fragment that blocks TNF. And we discussed that this, for example, does not cross the placenta. So some of these molecules may have very different properties, and this is another common theme that I ask you to have in the back of your mind. How you block and interfere therapeutically with 17 is also complex. Secukinumab and ixekizumab block IL-17A that may act as homodimer or heterodimer with IL-17F to activate the keratinocyte. You see this here, right? So an A blocker will block this and this. We are also having in development a molecule, bimekizumab, that blocks A and F, and the only difference will be that it will also block this IL-17F homodimer, and those of you that are familiar with the research know that in psoriatic arthritis, that may be a different story compared to just blocking A. We don't know yet. And then we have the molecule brodalumab in some parts of the world that blocks this blue receptor chain and thereby will have a much broader blocking effect. So there is also the question, how do we exactly manipulate our target 23 or 17? This is how you selectively manipulate 23. Ustekinumab blocks the molecule that is shared between 12 and 23. The 23 so-called 23 blockers only block the IL-23 specific P19 subunit, so they will not block 12. And today we think that IL-12 may actually have some anti-inflammatory properties in psoriasis, and we may think that 12 plays a role, for example, in the defense against intracellular pathogens. So if you ask me as an immunologist today, what would be the ideal target, 12 and 23 or just 23, there is increasing evidence that the answer needs to be only 23. So what are differences between the targeted therapies? You see some listed here. Some work better than others. This may not only be due to the mechanism of action, may also be related to the dose. Some you need to give every other week. Some antibodies you can give every 12 weeks. The 23 blockers have these long injection intervals, every 8 weeks, every 12 weeks. And this is probably explained by the mechanism of action and the fact that they have this upstream effect. Some drugs, even if you stop them, a subgroup of patients remains controlled for a prolonged period of time. Is this related to the mechanism of action that you block a teacher, that you block an educational cytokine compared to an effector cytokine? As we move along, we will understand this even better. And then there will always be differences between drugs based on their immunogenicity, their affinity, their potency, so characteristics that have something to do with the antibodies themselves. So even 3 antibodies that have the same target may behave differently in the practice. I'll just show you an example of an injection site reaction. Some drugs have this, others don't have this. Some drugs you need to give a very high dose. Some drugs you can go to a low dose, so on, right? So this is also something you need to keep in mind. Professor Strober will talk about this, but this is just a snapshot, an example that blocking 23 with guselkumab gives a lot more patients a PASI 90 response than using adalimumab in the dose that we have. When you look at the long-term control, and again, Bruce Strober will talk about this, it seems to be one of the advantages of 23 that as long as you give them, patients have a very, very high level and stable response, and you'll see one of my patients here. Psoriatic arthritis, very interesting. And be aware that neither guselkumab nor bimekizumab have a label in PSA as we speak, right? And this line separates phase 3 data of labeled drugs from phase 2 data of drugs that have no label. But it also shows you that if a drug like guselkumab is able to reproduce this data in phase 3, we may have a drug that not only works in psoriasis but also in PsA. I find this interesting, and it actually works better, at least as far as we can say, than ustekinumab. So what is the contribution of 23 to peripheral arthritis? Interesting question. I want to finish with one last thought. This now really is a look into the future. That is not something that is yet there. Some of us think that the reason that if you stop a drug, psoriasis comes back is due to the fact that an inflammatory memory develops in psoriasis if you let the disease run and run and run, what actually we often do in our patients. And that this inflammatory memory is actually carried by the so-called resident memory T cells. And there are the first papers that check for these resident memory T cells that have this phenotype, and they can actually show that when you treat psoriasis, resident memory T cells may go down. And it may be, this is speculation at this point in time, that these cells, because they depend on 23, go down more with 23 blockers than with other drugs. This is theory, right? We have to look into this. But what we do see is, and I show you here the example guselkumab, that if you take the drug away in responding patients, these are all PASI 90 responders, they have had their last shot at week 20, you see that there's a very, very, very slow loss of response. There are patients that half a year later still have their PASI 90 response. And I think we need to explore and understand this further as we speak. This is an important slide. It doesn't look sexy, right? It looks like a boring slide, but it's extremely interesting. It may include a revolution. And you know why? This is a slide that asks the question, what patients have a higher chance to remain controlled once they have achieved control if you take the drug away? Unexpectedly, higher drug levels came out with guselkumab. Unexpectedly, lower weight came out. But do you see this? Shorter disease duration. So in other words, when you let the disease run and ask your patients, when I ask my patients, when did your psoriasis start? They say 15 years ago. And then I ask them, how many months were you disease-free? You know what many of my patients say? What are you talking about? Disease-free. I always had psoriasis. This may reduce the chance of patients to ever come to a state where they are disease-free without current therapy. And with this, I would like to thank you. These are just some ideas. Now let's put it to the test, Bruce. How good is 23 blockade really in the daily clinic? Thank you very much.
So thank you, Kristian. If there were a take-home message from today's symposium, it should be simply that blocking IL-23 via inhibition of P19 effectively treats psoriasis, does so with infrequent treatment intervals, and does so relatively safely We have a number of drugs that do this, 3 which are approved. And as I'll show you, those 3 drugs have been put to the test in comparator studies, excellent comparator studies, against well-known drugs that we all have used over many years. And then in so doing, in examining these studies, we can see both the comparative efficacy and safety over a relatively long period of time. These are my potential conflicts of interest. Particularly, I was an investigator for the drugs that I will be talking about, and I'm a consultant to those companies that manufacture and market those drugs. So just to level set you, ustekinumab, which in my opinion was a sea change in psoriasis therapy 10 years ago when it was approved, has known efficacy. Roughly speaking, about 2 out of every 3 patients, or in some studies 3 out of every 4, achieve a PASI 75. If you like the PASI 90, it's about 40%. And if you like cleared, it's approximately 18%. That's just to give you a frame of reference with regard to what we're currently working with in current medications. Guselkumab is a P19 inhibitor approved for the treatment of moderate to severe psoriasis. In its Voyage 1 study, which was replicated in a Voyage 2 study, but I'll discuss the Voyage 1 study, guselkumab was compared to head-to-head with adalimumab at its standard dosing, 40 milligrams every other week. And you can see quite clearly that PASI 75 achievement rates for guselkumab are north of 90%. PASI 9, and stay that way, relatively speaking, at week 48. And the adalimumab achievement rates for PASI 75 are where they should be, roughly 70%, in line with its own clinical trials years ago, making these data believable. Now, the PASI 90 achievement rate for guselkumab is basically the PASI 75 achievement rate for adalimumab. That should put this drug's efficacy in perspective. And over the course of time, it continues to maintain that efficacy. PASI 100, 37% for guselkumab, roughly twice that of adalimumab, and over about a year's time, 47% PASI 100. Roughly speaking, guselkumab has about a 1 in 2 chance of getting a patient totally clear after a year of therapy. Now, what happens if you take a person in these same studies on adalimumab who wasn't achieving a PASI 90, who had what might be called an inadequate response, and switch them to guselkumab at its standard dose? These studies in front of you basically show that you more or less can convert that patient to a PASI 90 responder about 73% of the time over roughly a year's therapy. And this was replicated in 2 different studies. DLQI as well is upward of 2 in 3 patients get to a 0 or 1 DLQI, which is a more or less normalization of quality of life. So again, you can take inadequate responders to adalimumab and turn them into responders by the switch. The Navigate study was a switch study of a different type, where they took ustekinumab, quote-unquote, inadequate responders, defined as people who received ustekinumab 2 doses and didn't achieve a PGA score of 0 or 1 after those two doses. At week 16, these patients were switched to guselkumab, and as you can see in these two figures, patients who were switched did much better with regard to either getting to IGA 0/1 or PASI 90 when compared to ustekinumab patients who were maintained on ustekinumab. So here we see you can either switch adalimumab inadequate responders or ustekinumab adequate responders to guselkumab and achieve a high probability of success. This is a different kind of study. It's a head-to-head trial which matches guselkumab at its standard dosing, which is essentially a Q8-week interval of giving the drug after an initial 4-week 0 and dosed 1, and then Q8 weeks, matched against secukinumab at its standard dosing. And what you can see initially, secukinumab achieves a PASI 90 rate at approximately 12 weeks faster than guselkumab, but over time, guselkumab through 48 weeks gets a greater percentage of patients to PASI 90 than secukinumab does. And you can also see the statistical treatment of these data is extremely conservative, non-responder imputation, the most conservative approach to treating data. And the patients achieving PASI 90 in the guselkumab arm are stable, a flat line, whereas the secukinumab arm is declining slightly. So if you were to carry these data out over time, the difference between the two groups might even widen. Now, those of you who care about using fumaric acid esters, which might be a very narrow portion of the world, the summation of these data comparing guselkumab to fumaric acid esters is, as I put it, the amount or the percentage of people who respond to guselkumab after 24 weeks is the same as the percentage of people who don't respond to fumaric acid esters. So it's an inversion. It's no contest, however you look at it. Now, other people might want to look at absolute PASI scores. What are the absolute PASI scores through 1 year of treatment on the left, or absolute PASI scores through 3 years of treatment on the right? And on the left, we compare guselkumab to adalimumab, again, in the Voyage 1 studies, which were head-to-head. And as you can see, people absolutely clear on the far left, 50% of patients are achieving that on guselkumab and half as many on adalimumab. And if you care about PASI score of less than 1, which is not a bad milestone, it's again approximately twice as many patients and 2/3 receiving guselkumab as opposed to adalimumab. Over the course of 3 years, most patients achieve a PASI less than 5 or less than 3 on guselkumab. Half are clear. Safety. And what you can say about the safety for all the IL-23 inhibitors, in my opinion, is it's more similar than different. It's very hard to tease out, in my opinion, a difference between these drugs. They're relatively clean. They don't have obvious signals of infection, MACE, malignancy. The AEs are equally distributed across the treatment groups when you look at comparator studies. For example, in Voyage 1, guselkumab versus adalimumab, hard to see a difference. You might see more upper respiratory tract infections in patients getting IL-23 inhibitors. Serious infections, again, really no imbalance that's easily discernible between the groups. MACE are almost non-existent. Malignancies are extremely infrequent. Long-term through 156 weeks is a similar story. Very hard to see a discrepancy in malignancies that exclude non-melanoma skin cancers or non-melanoma skin cancer. No signal of MACE, no clear discrepancy in deaths, no clear discrepancy in infections. Turning to tildrakizumab, another approved IL-23 inhibitor, which also specifically blocks P19, we see data that are showing efficacy that's a bit more modest. 2 out of 3 patients, whether receiving the 100 or 200 milligram dose of this drug, achieve a PASI 75. And that response is somewhat increased if you extend the efficacy analysis over approximately a half a year. Perhaps 3 out of 4 patients now achieve that metric. PASI 90, it's more like 4 out of 10 at 12 weeks, and maybe 1 out of 2 at 28 weeks. PASI 100, maybe 1 in 4 achieve that benchmark at 28 weeks. Safety for tildrakizumab, nothing really to note. I could dwell on this slide forever, and I'd put you to sleep. So I will just state that there's nothing new here. No signals of infection that are noteworthy, deaths, no real signals of MACE, no real signals of malignancy, candidiasis, or other types of issues that would concern us. One thing I found interesting is if you get a lot higher serum levels of tildrakizumab, as shown here, when comparing the 100 milligram and 200 milligram doses, you don't see more infections. So it's interesting how you can up the volume on IL-23 inhibition within a certain limit, of course, but within the limits of these studies, and you don't seem to get more immunosuppression. So there's a large therapeutic window, it appears, with regard to inhibition of IL-23, at least in the doses we're able to use for people with moderate to severe psoriasis. Risankizumab is the third approved IL-23 inhibitor that we currently have to use for patients with moderate to severe psoriasis. It too was compared against well-known drugs. In the studies I depict here, Ultima 1 and Ultima 2, the comparator was ustekinumab. And we can see on the left that risankizumab achieves a PASI 90 75% of the time, whereas ustekinumab is in the 42 to 47% range, much like its pivotal studies. And I should also state PASI 100 levels varied between the two studies I showed here, 36 and 51%, but so did the responses for ustekinumab, twofold, which probably explains trial site differences and not behaviors in the medicines per se. This is a kinetic example of how the drug works over time, the green being risankizumab, the purple being ustekinumab, and there is a placebo arm at going through week 16. And it's interesting to note that at the primary endpoint, again, 75% of patients have a PASI 90 versus 42% on ustekinumab. And over time, approximately 82% at week 52 and risankizumab have a PASI 90 and 44% on ustekinumab. And note that the ustekinumab arm has a sawtooth appearance, implying there is some loss of response between injections, as sometimes we see in patients getting ustekinumab, whereas the evenness of the response over time seen with risankizumab indicates its dosing interval is more appropriate. Also on the right is a depiction of data over the long haul in patients who respond to the drug, PASI 90 responders, in an NRI analysis, reminiscent of what Kristian's slide for guselkumab showed in his talk, which over time, more or less 9 out of 10 patients in an NRI analysis keep their PASI 90 response, whereas the ustekinumab arm, 7 out of 10 keep their response who had an initial PASI 90 response. This is a switch study that exemplifies also inadequate responders to adalimumab as defined by people who did not get a PASI 90 in the adalimumab arms of patients in those studies for risankizumab. On the far left are people who received risankizumab continuously throughout the study and their PASI 90 response at week 44, 3 out of 4 patients. In the middle, we have people who were initially on adalimumab but achieved a PASI 50 to PASI 90 response and who were switched to risankizumab. You see these patients have a slightly inferior response to those who were continuously on the drug, all from the beginning. And then on the far right, we have adalimumab non-responders who achieved less than a PASI 50, and they too, while showing a response to a switch to risankizumab, it is slightly less than the people who had a 50 to 90 response. So it suggests we can switch adalimumab patients to risankizumab and get success, but perhaps the adalimumab failure patient or inadequate responder patient is a little bit more difficult to treat. The secondary endpoint of PASI 100 on the right basically depicts the same kind of responses. Safety with risankizumab, similarly, is a lot of numbers which suggest very similar conclusions as I just told you for the prior 2 drugs. Essentially, upper respiratory tract infections account for the infections that occur a little more frequently in people getting risankizumab. And the signals are very similar to the comparator groups in their studies, namely those to ustekinumab and adalimumab. There's no MACE, basically. There's no activated TB, reactivated TB. very few malignancies beyond what we'd expect from baseline, and very few to no deaths. Serious infections are in line with what we see in other clinical trials for biologics, some cellulitis, pneumonia, again, no MACE. Injection site reactions are not more than comparator groups. And interestingly, one thing that is noted is a smattering of tinea infections in people getting risankizumab. So that accounts for a slight signal of what's called fungal infections. Tinea corporis, tinea pedis, even tinea versicolor. Malignancies are seen what I'd see as a comparable level to the comparator groups during those periods when they were being compared, and over long-term analyses of risankizumab, the rates of malignancies expressed as a per 100 patient year value are what you would expect for patients with psoriasis, a low level and unchanging, if not decreasing over time. Again, this is a summary of the infections that are seen in the long-term analyses of risankizumab. There was a couple cases of zoster that were dermatomal and did not necessitate discontinuation of drug. Just a few points about latent tuberculosis. It's interesting that in all instances of patients enrolled in studies for P19 inhibitors, there were patients who tested positive prior to entry of the study for latent TB and were allowed to be prophylaxed or treated for latent TB with standard local regimens. And in almost every instance, there was no case of reactivation of TB. So people from Janssen did a nice analysis of a large number of patients in their studies. Upwards of 70 patients were pre-treatment positive or tested positive during the study for latent TB, and none of them reactivated. The labels for all three drugs are very comforting with regard for TB. I should note these are the US labels. Guselkumab, the label documents 105 subjects with latent TB who were concurrently treated with guselkumab and TB prophylaxis who did not develop activated TB with a mean follow-up of 43 weeks. Risankizumab had 72 subjects who were prophylaxed, who were pre-treatment TB positive, latent, prophylaxed, and did not reactivate. In fact, risankizumab had 33 patients who were enrolled in the studies and did not get prophylaxed and receive drug and did not reactivate their TB. And finally, tildrakizumab pretty much had a large number of patients. One subject developed TB while receiving tildrakizumab, but none while receiving TB prophylaxis. So we'll skip the question and we'll go right to the conclusions. IL-23s deliver robust and long-lasting efficacy, as stated by Kristian earlier. In so doing, their dosing is infrequent and variable, every 2 to 3 months. And likely, they have a mechanism of action that's highly tolerant of dosing variability or error. I would say lazy dosing is tolerated. Patients can miss the dose by a week or 2 or 3 and maintain their response. IL-23 inhibitors provide better efficacy and apparently equivalent safety to ustekinumab. It's safe to say there's so many comparator studies that we can come to that conclusion. Over time, I believe they'll replace ustekinumab and become first-line therapies. Their efficacy for psoriatic arthritis, as Kristian alluded to, is left to be determined. Their efficacy in reducing systemic inflammation as well is left to be determined. And finally, it's important to note there's very little that contraindicates the use of an IL-23 inhibitor. So if you have a patient with comorbidities in front of you, it's safe to say there's little that would dissuade you from using that drug. They're appropriate for patients with inflammatory bowel disease, multiple sclerosis, and perhaps liver disease and heart disease. In other words, comorbidities probably are not a scary thing when thinking about using an IL-23 inhibitor. And with that, thank you very much.
Are there any burning questions? Bruce, can I ask you one question? You showed us the clinical data for 3 different IL-23 P19 inhibitors. And if I followed your slides correctly, I saw this very high level of responses, mostly for risankizumab and guselkumab. Tildragizumab seemed to fall off a little bit, at least in the, let's say, first 24 weeks. Is there any explanation why you see this difference between the different 23 inhibitors?
Yeah, so it's an excellent question. In essence, we have the same target, P19, yet we don't always get the exact same efficacy. And it might have to do with the molecule, and it might have to do with how the molecule targets its specific target, P19. They don't all, for example, have the exact same half-life. They might not all have the exact same tissue penetration. They may not all have the exact same binding affinity. And also, it may matter where on P19 they specifically bind. It's interesting that if you double the dose of tildragizumab, you don't get incremental improvement in its efficacy. There's maybe some slight improvement in its long-term efficacy, and I've seen those data. Tildragizumab holds efficacy better at 200 milligrams than 100 milligrams out long-term.
Yeah, thank you very much. Are there any questions? If not, Bruce, thank you very much again.
My pleasure.
So I've talked about the pathophysiology, the mechanism of action. I think Professor Strober did a wonderful job in really carefully reviewing in a very balanced way the available data for 23 inhibitors. My reading is they work very well. They are very safe. They are convenient. They seem to be very attractive drugs. But Curdin, we still have to use and will use the different classes. Can you give us any guidance which is now the right targeted therapy for our patients, please?
Thank you. I mean, first of all, I cannot give you any guidelines. I think that's a little bit too much to ask. But I can give you some recommendations, and I think it's important that we have profile our patients in order to know in which patient actually to do which drug. So these are my disclosures. I'll skip over them. So if you have a chronic disease, no matter if it's psoriasis or something else, you always have to think you have to find the optimal option for every single patient, which offers you the optimal balance between the risk and the inconvenience on one side and the benefit and the efficacy on the other. And that obviously changes from one patient to the other, from severity to the other. So you have to individualize, personalize your medicine. And with the approval or the coming of the anti-TNFs first, but the biologics in general in the early 2000s, they completely changed the management of our patients. But now with the ever-growing treatment arsenal that we're having with 10 and more biologics actually on the market, it also becomes a bit more difficult to say, okay, for which patient I'm actually going to take which drug and which one I'm going to take first. And to show that this is actually a very critical, important question, there is a recent publication from Alexander Eggeberg and colleagues who showed that in this case with secukinumab, if a patient was put on secukinumab as a first-line biologic, but after 3 years, 80% of your patients are still on the drug. If this is a second-line biologic, or even a third or more, this possibility or this chance drops down to 50 and then below to 30%. So it is extremely costly for the healthcare system, but also for the patient themselves, that you have in the first run the right drug. Now, how do we choose? And here, actually, the guidelines coming out all the time, more or less, are only partially helpful, or I would say not at all helpful at all, because they tell you when to start, but not actually which drug to start and in which patient. So what are the factors that drive into consideration or that influence our optimal choice? And there's obviously some drug-related factors that we heard from Bruce and also from Kristian before. So there's efficacy, safety, the convenience, which again has an effect on the compliance. These are then individual patient-related factors such as age, sex. Is a woman of childbearing potential? What is the demand or expectation? This can even in a patient with the same severity be different from one patient to another. And then there's more general disease-related factors, such as disease activity, disease course. What are the phenotype, the variants? Is there nail psoriasis involved, palmoplantar psoriasis? Is there arthritis involved? And then the severity and this impact, and very important, and we heard before from Bruce, the comorbidities have a critical impact. And all that together has an effect on the drug survival. So starting with the efficacy, so obviously, just an additional point. So no single treatment that we have, no single option, even today with the anti-23s, are effective or are appropriate for all our patients. Now, starting with the efficacy, early on we didn't have any head-to-head trials as we've shown before, and Kristian Reich here in 2011 published a first meta-analysis to compare these drugs. At that time, the companies did not dare to actually do head-to-head trials, and so we did that indirectly. And what was shown is actually that ustekinumab is slightly better than the subcutaneous anti-TNFs. But now, 4 or 5 years ago, the anti-IL-17s came onto the market, and they towered ustekinumab clearly. And you can see that as early as week 2 to 4, there's already a significant better response rate in the anti-IL-17s. And then a PASI 90 suddenly became a treatment goal in our patients. And now last year, actually, the IL-23 specific blockers came onto the market or entered the game. And now you can see that PASI response rates were even higher, as we heard before, and a super maintenance of this efficacy, very robust data, but yet no head-to-head trials at that time. So in the first time in 2017, there was an indirect analysis of that. So how do they fare? Where are the anti-IL-17s? Where are the anti-IL-23s? And actually, in this meta-analysis, Cochrane database analysis, you can see that actually IL-17 fared better. They were above guselkumab, so above the IL-23. Now, Bruce showed you before that actually the IL-23 blockers are doing better. And that was shown in the head-to-head trial. So you have to look into the data more detailed, particularly if you do meta-analysis. They looked at the primary endpoint. And if you look at week 12, actually, as Bruce showed before, secukinumab, so the anti-IL-17, fare a bit better. They have a high response rate early on, but then the IL-23 take over, and then after 6 months, then actually become clearly more robust and a higher response rate. So if you were looking for a very fast response, you might want to go for an anti-IL-17. If you're looking more down the road, a more robust response rate down the road, you're probably going to tackle an IL-23. So what about safety? And early on, again, in the meta-analysis, again, indirect data, but from randomized controlled trials, there was first analysis to shed like anti-TNFs and ustekinumab have about the same side effect profile. But if you look at the real-life data, it's actually a completely different story. So the anti-TNFs have been clearly shown to have a higher risk for serious infection. Ustekinumab, so blocking IL-12/23, you have a lower risk for withdrawal due to adverse events. Even more so, actually, anti-TNFs have a very particular side effect profile with a very severe, no, moderately severe, but critical specific side effects. So you have paradoxical psoriasis and lupus-like syndrome, which only occur in anti-TNFs. It's a class effect of anti-TNFs. You have the risk of tuberculosis reactivation, as we heard before as well, is more or less negligible in all other drugs except for anti-TNFs. So if you have a patient with a latent tuberculosis, you're probably not opting for an anti-TNF. And this is the rheumatologist currently actually discussing if you're not opting for an anti-TNF, that you're and you're not actually obliged to do the TB screening at all anymore. And then there's the ongoing discussion about MS and lymphoma around the anti-TNFs. So it seems like efficacy-wise, the anti-TNFs are losing slowly ground, and also on the safety side. So what about drug survival? And again here, ustekinumab, clearly more solid, clearly higher chance that the patients remain on the drug over time, while the anti-TNFs are actually about 50% of your patients will be off the drug in 3 years. Discussion ongoing about the anti-IL-17s, probably they're somewhere in between. There's no data yet on guselkumab or the other anti-IL-23s, but the data look rather solid. So in your general patient, I would say with no comorbidities, no other options or no other problems, you're probably rather safe with ustekinumab, anti-IL-17, and particularly, as we've heard, the anti-IL-23 blockers. But what are the drivers now, particularly patient-related drivers that can change your decision-making and get the right drug early on? And here probably the easiest one is psoriatic arthritis. Here still the anti-TNFs remain the absolute gold standard. They have the most solid and most robust data for all types of arthritis, followed by the anti-IL-17 and probably a little less ustekinumab and the IL-23s. That doesn't mean that all your patients, the 20 to about 30% that have arthritis, have to be put on anti-TNF. But it depends if it's the main driver. So if you have severe arthritis and mild psoriasis, you're probably going to go with an anti-TNF. If it's a mild psoriatic arthritis and severe psoriasis, you probably go with one of the others. So what about inflammatory bowel disease? And actually, IL-17 was a very, very interesting target in that disease. But suddenly, when Novartis launched the study, they terminated their development early on because they had more side effects, a higher risk of adverse events, and the lack of efficacy. And there's actually new onset IBD and aggravation of pre-existing IBD in patients treated with anti-IL-17. And the question was, how is that actually possible? If you block IL-23, the driver for Th17, and you get improvement of colitis or Crohn's disease, while you block IL-17 directly downstream, you can get an exacerbation. And Kristian just tackled that early on a little bit. This chance or a serendipitous description in the clinic actually led to the description scientifically of two subtypes of Th17 cells, the pathogenic and non-pathogenic T cells. And while the pathogenic ones are strictly dependent on IL-23, they produce an IL-17 and 22, so they're clearly pro-inflammatory, while the other one, in the absence of IL-23, is also producing IL-10, which is also regulatory function. Critically is that actually only the pathogenic Th17 cells drive the tissue inflammation, while both of them, through IL-17, also have protective function through barrier function repair and the control of bacterial growth. So if you're removing all IL-17, those drivers can get out of control and you get aggravation of your IBD, while if you block IL-23, you only get rid of the pathogenic ones and you have the effect of the reduction of the inflammation, be it in the skin, be it in the inflammatory bowel disease, without the risk of aggravation. So if you have patients in your family or a personal history that have inflammatory bowel disease, you're probably not opting for an anti-IL-17. That doesn't mean you have an absolute contraindication for anti-IL-17 blockers, but you're probably going with another drug, such as anti-TNFs, particularly antibodies, or ustekinumab, which even have IBD in their indication. IL-23, I would bet right now, is probably up here in a few years. The studies are ongoing and most likely will also have a good effect in Crohn's disease. Afterwards, etanercept, it's not effective in IBD, but you're not facing the risk of aggravating inflammatory bowel disease. What about latent tuberculosis? We heard that before, IL-23, absolutely safe. It's also for the others. It's particularly or almost specific problem of the anti-TNFs. So if you have a patient with latent tuberculosis, you're probably not opting for an anti-TNF in the first place. Another chronic infection, hepatitis B. I'm not going into all the details now of the results of your screening testing in the meantime or what you got. But what I want to show you is actually that even if you have occult infection or resolved clinical infections or previous hepatitis B, you have a certain risk of reactivation of your hepatitis B under anti-TNF. And that is, again, specific for anti-TNFs. There are reactivation under ustekinumab and IL-17 blockers, but it's only if you have the antigen to the hepatitis B, surface antigen, or the hepatitis B virus DNA detected, then there's a certain risk, but not in the case of actually resolved infection. So again, that's probably not your first choice if you have patients with a previous hepatitis B infection. Again, all the others do not face that issue. So what about pregnancy? So in general, I'm rather opting towards interrupting the treatment in my patients, at least. The data out there are a lot of data, but I'm not really that keen on continue treating them. But what you can see is actually there's a reassuring recent publication that showed in female patients, well, obviously female patients, that were pregnant, and they showed that at birth, who got sertolizumab during the pregnancy, at birth, they had the drug levels at the correct level, so at what you would expect, but none of the infants had detectable levels of sertolizumab. There was one single one with very, very low levels, and it was actually coming from the mother with the highest dose drug levels in the system. So it might be, if at a very, very high level of sertolizumab, there is a minor transfer across the placenta, but in general it's considered irrelevant. And so you have a lack of placental transfer of sertolizumab during pregnancy and breastfeeding. So this will be probably, if you need a treatment during your pregnancy, the most reassuring data, and probably the one you would choose over the others. There's a lot of data on anti-TNFs in general, particularly from arthritis patients, but I would go with sertolizumab if needed. So what about our children's? This is a typical patient from our clinic, received Enbrel dose adjusted to the weight with an excellent response after 12 weeks. So what were we here? And this is the situation in Europe, so I don't know about anywhere else. But as you can see here, since 2015, we have adalimumab from the age of 4 years old and ustekinumab starting with the age of 12. But actually, etanercept, we have a 15 years experience and huge data sets on these patients, so that's why I'm clearly opting first line in my patients always or almost always with etanercept. Gives you also the benefit that you can actually stop the treatment after a while, 6 months or 12 months, and then see what's happening, restart, because the disease course can also alter during the adolescence, so you might want to have that option. So this is another summary of other factors that might influence your choice. Again, this is a personal opinion. It's not guidelines. It's not set in stone. It's not black and white. But it gives you a certain driver to choose the correct to choose the correct drug. So lupus paradoxical psoriasis, told you 4 specific side effects for anti-TNFs. Doesn't mean that these are contraindicated. You're probably opting for something else. MS, we heard, no risk for IL-23, but probably the other ones are at the moment a bit more safe. IL-17 blockers even show a beneficial effect on MS, so after discussion with the neurologist, that might be your way to go. You're certainly not going to use the anti-TNFs as is with congestive heart failure. Uveitis, probably very underestimated in psoriasis patients. Anti-TNFs remain the absolute gold standard. Overweight, ustekinumab and inflamiximab, because you can actually adjust them to the body weight. I prefer a little bit ustekinumab because it's at a flat pricing, at least in Switzerland. IL-23 is probably in the future as well very good, because even in the more obese patients, they show very robust efficacy rates, so they don't drop as, for example, for adalimumab. If you have patients with malcompliance, or you doubt at least their compliance, ustekinumab, infliximab, and anti-23s are certainly good options, because you can inject them every 12 to 3 months. So you can do it in the office, you can do it in the clinic, and you know that they got their regular dose as needed. These are the factors I told you before. Again, this is not taking into consideration that there are actually biosimilars out there, which might alter your decision tree and the effect if all these drugs are actually available in your countries. But it gives you a little bit an idea how to choose your drug, particularly in the first one, correctly. Again, if you have IBD, obviously anti-IL-17s are not contraindicated, but it's probably not your first choice. Same for latent TB or occult or recent hepatitis B. You would probably not opt for an anti-TNFs, but rather another drug. So what about the future? And I think that is extremely critical. There's a lot of research going on all over the world with biomarkers now, and we're unfortunately not there yet. There are some biomarkers out there that we can know of. So it's HLA-CW6, which predicts better response for ustekinumab, and a recent publication by the SWORD Consortium from the UK has shown that actually as early as week 1, so after one single injection of 80 milligrams of adalimumab, you can measure the drug levels, and if they're above 7 micrograms per ml, you have a higher chance of achieving PASI 75, so it's 80%. If they're below 3 micrograms per ml, you can more or less stop the treatment, because your treatment response is dropping dramatically. Now, is this useful? I think in the clinic probably yes. I'm not sure if any one of you or every one of you has the possibility to actually measure that quickly, the anti-drug antibodies, but this is certainly something in the right direction. Obviously, we would like to have something which actually drives our decision tree prior to initiation of the treatment. And so this is my final slide. Again, this is not guidelines as you asked me to do, but I hope to give you some idea how to choose your treatment correctly. Do you have to personalize your therapy, particularly the biologics, that you choose the first line biologic particularly correctly, treat the patient and not psoriasis, not the disease, with all its comorbidities and everything. And again, very, very importantly, there's not a single biologic agent or class which can be used to treat all your patients, because all of them have unique benefits and limitation depending on drug-related, patient-related, or disease-related factors. And with that, I kept in time, and I thank you for your attention.
So, thank you very much, Curdin, also for putting your personal perspective on a slide. Bruce, my first question to you: if you saw these last two main slides with the green and the not so green and the red, and yes, you said it's a personal opinion, how would you, in this elevator talk, right, 1 minute, how would you use the different classes? Is there still a role for anti-TNFs? Are they being replaced by the 17? Is there still a role for ustekinumab? Are they being replaced by the 23 inhibitors? Do you consider these drugs still new? Would you advise us to wait? How do you see this, Bruce?
I mean, I think, to be honest, I feel very comfortable with the IL-23 inhibitors and the IL-17 inhibitors being first-line drugs, biased towards the IL-17 inhibitors if there's significant psoriatic arthritis, and biased towards the IL-23 inhibitors. For pure psoriasis, the infrequent dosing is very convenient. I mean, I might be the biggest user of ustekinumab in the US, so I'm not one to easily insult that drug, but I think its time has passed, and there are now superior drugs to ustekinumab out there based on data and experience. So same with the TNF inhibitors, which payers mandate the TNF inhibitors, and I'd have to say that's probably the only reason why I currently prescribe the TNF inhibitors, because payers mandate them. But in my opinion, there are better options, more modern options.
Yeah. Curdin, a question to you. A patient that has significant nail disease. This I could not really take from your slide. So someone comes in, has a PASI 10, but has 10 out of 10 fingernails involved, with severe nail psoriasis, has failed methotrexate and has failed phototherapy. What would be your first biologic? Again, a personal opinion.
Well, I think the anti-TNFs and the IL-17, all of them are in the end probably effective. It takes a bit longer or less, but I think the anti-TNFs do play a good role. Anti-IL-17s, I think it depends a little bit again if it's just the nails or if it has some more severe disease, then I would probably or certainly go for an anti-17. So again, there's not one single driver usually. So there's a lot of comorbidities and variants and disease scores which drive your decision tree in the end. But I think in the end, anti-TNFs and IL-17s, they are certainly still very, very good.
Now, a last question to you both, and this is also a question we have here from the auditorium. We talked a lot about clinical data. Bruce, you gave us a perfect overview. Now, what about the real world? And we are all aware that no registry yet has thousands of patients with 23 inhibitors because they are just the most recent class. But my first question to you, Bruce, and you have done great work with the Corona registry in the US. Curdin has shown these differences in the drug survival rates. Yep. What's your guess? Where will the 23 inhibitors in this game, where will they come up?
They're going to be as good or better than ustekinumab in drug survival.
So the long-term durability of the response, that's one of their
They're going to be superlative.
Yeah, Curdin, would you agree with this?
I want to see the data first. I'm not 100% sure on that because to be honest, I was surprised with the secukinumab data when the Danish registry came out. They were really, really bad. They were even worse than TNFs. Now, with all the new data coming out, they got up a little bit and probably in between. I hope they're better. I agree with Bruce, but I want to see the data first. I don't want to be surprised again.
Yeah. I think we have had all a long day, so please allow me to kind of close and give you a little summary. I hope you share with us that the arrival of the 23 inhibitors is another specific broadening of our therapeutic armamentarium. And Bruce, you showed us 5, 6 out of 10 patients PASI 100 after 1 year. That is amazing data, right? There is no one-size-fits-all, though, and we have seen the 17 inhibitors. There are great drugs in arthritis, as I heard this from you both. We have fantastic data in nail disease. The risk profile, let's not forget this, is very different between the targeted therapies. You showed that the safety events of interest, they are similar, but Curdin, you showed that there are also target-specific safety events, TB, Candida, IBD, MS, that may drive you away or towards a certain drug. In the end, and this is now really my last word, I think today there is no excuse that we really manage our patient with psoriasis well. And we have anti-TNFs, we have 17 inhibitors. I think, once again, the 23 inhibitors are great. They give you high levels of response. They seem to be extremely safe. They seem to give our patients very stable responses. And I'm very glad that I'm now in the situation, actually, when I see a patient with moderate to severe psoriasis coming in, I smile internally because I know I can help these patients. So for us, psoriasis as a model disease, I think we have achieved great things. Thank you for contributing to this. Thank you for coming. Thank you, Bruce, Curdin, for doing this together with me. Enjoy the rest of the day. Enjoy the symposium.